My name is Wayne Stafford and I'm an electrophysiologist and have been for about 30 years. I'm also one of the founding partners of QCG. I've always been interested in sudden cardiac arrest and the use of implantable defibrillators to treat that problem. Sudden cardiac arrest is a major worldwide problem in health. About 3 million people worldwide die every year from sudden cardiac arrest, and that means about 33,000 people in Australia every year. That makes sudden cardiac arrest a really major problem in terms of healthcare. There's a lot of confusion in the community regarding what a sudden cardiac arrest is. Most people regard it as a heart attack, when in fact, by a heart attack, it's usually implying that there's a sudden occlusion of a coronary vessel causing a myocardial infarct. In fact, that accounts for only about 20% of sudden cardiac arrests. 80% of them are in fact an abnormal heart rhythm. A cardiac arrest is the onset of a sudden rapid ventricular tachyarrhythmia that causes the cardiac arrest. One of the major problems in sudden cardiac arrest is the survival. If somebody has an out-of-hospital cardiac arrest, fewer than 5% will survive to leave hospital. So that it's a critical problem to try and identify these patients before they have a cardiac arrest and not wait for them to have the problem to declare itself. Secondly, of those who do survive, at least 35% will have a recurrence within 1 year and 45% by 2 years unless they receive appropriate treatment. On the other hand, early defibrillation, such as an automatic defibrillator, will result in significantly improved survival of around 70%. But of course, what we really want to do is to have defibrillation immediately that leads to much higher survival rates than that, and that's where implantable defibrillators come in. There are risk factors that help us identify patients who are at high risk for sudden cardiac arrest, and these would include left ventricular dysfunction, and particularly an ejection fraction of 35% or less. That may be a prior myocardial infarct or cardiomyopathy. Also, patients who have had ventricular tachycardia are at particularly high risk. There are genetic heart diseases such as channelopathies that predispose to sudden cardiac arrest. Patients who have heart failure are particularly predisposed to sudden cardiac arrest. An echocardiograph is a very simple and effective tool for stratifying risk. If you do an echo and a patient has a left ventricular function with an ejection fraction of 35% or less, then you automatically know that this patient is at increased risk. Other investigations can sometimes be also very helpful in identifying risk. Particularly performing programmed ventricular stimulation with an EP study can be a very effective way. If VT is inducible at the study, then those patients are identified as being high risk. Having identified a patient at high risk for sudden cardiac arrest, it's appropriate to consider referral to an electrophysiologist. Assessment can then be performed to decide what's appropriate treatment, and that may include a primary prevention ICD. But there are some treatment options that we should consider first. It's important to treat underlying problems such as electrolyte disturbances, myocardial ischemia, heart failure. There are medications that we know significantly reduce the risk of sudden cardiac arrest, particularly beta blockers, ACE inhibitors, and angiotensin receptor blocking drugs. A commonly asked question is, well, why don't we just put them all on amiodarone and that should protect them against having a cardiac arrest? And the answer is that in fact the controlled trials show that amiodarone doesn't protect against sudden cardiac arrest and doesn't improve survival. So my message would be, firstly, to be aware of the risk factors and to assess particularly left ventricular function. And an echocardiograph is a very simple tool for identifying patients with an ejection fraction of 35% or less who are at particularly high risk. Having identified those patients, consider referral to an electrophysiologist for further assessment. And remember, waiting until the condition declares itself is waiting too long.